Hi everyone, I'm Kristen Lindauer and I'm here with Brenson Wolf. We are the co-founders of RX Teach, and today we have a very special guest with us, Alex Poppen, who has been featured on RX Teach before. If you've read our Biostat tips post or multiple journal clubs, Alex has been graciously offering some of his work to RX Teach. So a little bit about Alex is he earned his Doctor of Pharmacy from UMKC in 2018. After graduation, he did some time in retail pharmacy and published the book High Powered Medicine. And after he published this book, he caught the eye of someone at Pearls, if you're familiar with that resource, and has been with Pearls ever since.
Nice to meet you guys. And yeah, just wanted to that pretty much covers it. I've been working with Pearls for the better part of 2 years now. I was one of their medical writers and basically putting together the drug pages and also curating any treatment guidelines and just other fun content related to pharmacotherapy and, practicing medicine and just trying to make a better resource for clinicians. So I've been very lucky to have that opportunity, and I'm excited to talk with you guys today.
If you haven't seen some of the Pearls information, it really is very helpful. Helps break down complex topics into fun graphics. And so today, the purpose of this interview is relating to our recent RX Teach post on cryptogenic stroke, if you found that in your inbox last week. And Alex here has a firsthand experience with cryptogenic stroke, and he's here to discuss his experience and all of the information he learned from his labs, his imaging, his follow-up appointments. So we're just here to get his experience and see what he has to share.
So, Alex, obviously, I know this was a crazy experience for you. Let's just go ahead and, start from the beginning. So, what were you doing? What happened? What did it feel like? Maybe you can walk us through the start of this entire journey and how this all kicked off.
Yeah, so a little bit of background about me, I guess, to kind of qualify it. Otherwise healthy, 29-year-old guy, and had no, comorbid conditions, no known health issues. I've been thankfully very healthy most of my life. So about at the end of August of this year, it was a normal Saturday. I'd taken the dogs for a walk. I'd been doing some yard work. And then that night I was home alone and I was reaching down to give our dogs their dinner, and the dog food cup slips out of my hand and my arm just kind of goes dead. And I was like, okay, that's weird. I gave myself a dead arm or something, like, well, whatever. And then I'm like, well, I can't move it. And I could feel in my mind, I know where my arm and hand should be, but it's just hanging down at my side. And I'm starting, oh, this is super weird. And I'm feeling this left side of my face, and it was the left arm, left side of my face starts going numb, like you would get at the dentist office if you get lidocaine or Novocaine for pre-treatment anesthesia. I'm like, oh, that's really weird. And then as I'm kind of talking out loud to myself, like, whoa, and it's like really garbled, muddy speech. And like, I can feel like just the whole, just numbness kind of spreading down a little bit. So I've never had any pain, and there was no like precipitating factors and didn't hit my head, didn't have anything really to kind of, I guess, cause the reaction. And in my mind, I'm like, well, these are all the three hallmark symptoms of a stroke, like dead, like arm, face, speech. Like, well, that's can't be it. It's I'm 29. This is like impossible. But at the same time, I'm starting to panic because I'm like, well, gosh, what could this be? Could this be some weird like palsy reaction? And like, well, I'm home alone. I probably shouldn't just wait to just figure it out as we go. So because if it was going to be a stroke, I was like, well, this could go sideways real quick, and I can't resuscitate myself. So, or the dogs can't help out. So I go ahead and go make the call at the 911 and go wait outside for them to pick me up. The ambulance comes really quick and they get me in and they hook me up to get my vitals and do a rhythm. And it's like, oh, they're okay. Well, yeah, vitals are good, your rhythm's good. You're like, so what's going on? Like, what'd you take? Which is a kind of a, I was a little angry when they asked that, because I was like, no, this is not drug related. But as an EMT, like that's got to be half of what they're doing. So I don't fault them for that. And I was like, no, it's not normal. I didn't take anything. Like this is like, what else could this be? Like I need to go to the hospital. I'm just getting a little agitated at the time. And so like, all right, sure. They call it in. They're like, well, potential stroke. Go ahead and get ready for him, because they were taking me to a very close stroke center. Thankfully, also very lucky. And they get me on the gurney. They get me into do a CT of my head, chest, and um, it comes like they do it real quick and comes back, and the initial impression is, well, no brain bleed, which is awesome. And I was like, that's great. And they also didn't have any findings for stroke. And I was like, okay, thank goodness. Because the whole way over, I'm like, oh my gosh, if this is stroke, they're gonna have to give me TPA. And like, oh geez, it's kind of, I mean, it's not a benign treatment. There's a fair chance or a very real chance of it causing a brain bleed or some other serious bleeding event. So I was like, oh man, thank goodness. Like, no, where they get the impression from the radiologist, like, they have no TPA, we're not going to do stroke, or there's no findings for stroke, so we're not going to do TPA. We're going to just get you in observation. We're going to take a little bit more time to look at this. And I was like, okay, thank you. And from there, I was like, oh well, I better call my wife. So give her a phone call, and she couldn't really understand me because my speech was still pretty messed up. So I texted her and dropped my location, and she comes flying down the highway to come find me. So that was very upsetting, of course, for both of us to have to, she sees me and like the whole side of my face is drooped down, and I don't sound very good, and I'm in the middle of a busy ER, just kind of by myself. So not fun. We had a heartfelt moment there, but from there they like, all right, we're just gonna have you in the ER, and we're gonna wait for the attending to come by, the hospitalist, and take a look at you. So that's kind of where the first hour of the event was.
So how long was it until the attending came and saw you? Like, and since they said it wasn't a stroke, like what else is going through your mind at that point of why you would feel this way?
So it was several hours, if I recall. It was not, I mean, again, like I'm otherwise stable hemodynamically, and I'm coherent, and I was getting up to walk to go to the bathroom. I mean, I didn't really have great use of this hand. I mean, I could move my arm, but like the wrist and like the coordination was just, it was non-existent at the time. So they were like, oh, okay, well, that's weird. In my mind, I'm thinking, well, some sort of pinched nerve, maybe some palsy, maybe. And I was like, well, I'm not sure what they're going to do, but eventually they come back, or the attendant comes by, and he does a little assessment, and he's like, well, this is super weird. Like, these are atypical presentations. You're way too young for the average person to be having a stroke. And but at this time, like my tox screen came back negative, so they were like, okay, well, it's not drugs. Like, that's helpful. And I was like, yeah. Again, like not faulting them for thinking that, because what else could it be, just at the surface level. And so yeah, we're there. He's like, well, we don't know what's going on, but I'm going to consult neurology, and we're going to get you in for an MRI first thing in the morning when it opens up. And I'm not sure if there was just no availability for, or no staffing for overnight MRI, or what the case was, but they the next morning they do an MRI, and it comes back pretty quickly that I had a stroke on this side of my brain, relatively small and very localized. And you can pull that image up of the MRI, it was kind of cool. I had never really looked at an MRI or had to look at an MRI, but it was nice to be able to get those images after I got back home, and kind of just play around with like scrolling through it and see all the 3D transitions and all that stuff. So if you're ever, so that's what it looks like. The white part is the area of infarct, and the gray material is just like normal brain tissue.
So Alex, I believe in a previous note, like they had discussed with you that their quote unquote TPA was not going to be used. Was this conversation before the MRI, or
Hmm.
was it okay? So I was gonna say with the timeline I was confused, but they didn't find any symptoms of stroke signs of stroke at first, so I was confused about what that conversation actually looked like for TPA.
Yeah, so it was it all happened relatively quick. I was, they got the imaging results back rapidly, and there was no evidence of, or again, I'm not going to say that they didn't see it, or if it was there, but there was no evidence at the time of a ischemic stroke or hemorrhagic stroke. So at, based on that and the fact that, again, my symptoms were relatively minor compared to, I'm sure, most patients who come in and their whole body's disabled, or they're non-coherent, they've got cognitive impairments, and me just kind of coming in a little bit lopsided and otherwise doing okay. They were like, well, the treatment benefit risk, we didn't discuss it at length, but the agreement between the ER doctor who was talking to me and the radiologist was, hey, we don't have any findings. Yeah, probably don't need TPA. He came to me and I was like, yeah, we don't think we're going to do TPA. And I'm like, yeah, please don't give me TPA. And again, like thinking back, like, oh, if they had done the MRI like immediately after, or if they did that first, I mean, again, knowing what I know now, I probably would say, don't do the TPA. And wrong or right, like it's just, I was pretty, knowing what I know, knowing how I am now and how I've recovered, I would not want to chance it with a TPA. And again, that's not a treatment it's not a recommendation to apply to anyone else, but just from my own experience, I was very nervous about getting something like that. And again, like the guidelines even state a little bit, if your stroke severity is so minor, they actually don't recommend administering it because the overall treatment benefit's neutral and there's no added benefit compared to the risk. So but at the time, of course, none of this was known, and it was just like, oh, something weird happened, we don't know, we're gonna have to just wait and see. And they were busy doing other stuff, and I was, they had me hooked up to vitals, and I was beeping fine. My blood pressure was over, what they needed it to be. So I was not a pressing concern at the time.
Yeah, it definitely sounds like your history of being a pharmacist and having that doctor of pharmacy and working in healthcare definitely helped you kind of know what to expect, and then gave you that knowledge of like, well, if TPA is on the table, am I going to say yes or no? Because you know how detrimental it can be if things go wrong. So even though you didn't receive TPA, did you receive any other medications in the emergency department? What else do they administer for other strokes that come in?
So they didn't do any, I guess, what you would call emergent treatments. Because I was there overnight, they gave me a shot of Lovenox in my stomach, enoxaparin, just because they thought I wasn't going to be mobile, or that I shouldn't be moving around. So that's just part of their, I'm sure, protocol for anybody who's hanging out too long, just to make sure they don't have another clot. But yeah, that, and they'd initially start, like, again, but after the MRI came back, they gave me aspirin, Plavix, and atorvastatin, 40 milligram, to just go ahead and get that process started for dual antiplatelet therapy, and just a kind of giant catch-all for anybody who has some sort of cerebral vascular events. I'm sure it's part of their protocol just to get that started. And but other, I mean, like my lipids and all that stuff didn't show any sort of crazy elevations that would be suggestive, like, oh, this is clearly due to some sort of atherosclerotic formation or anything like that. But other treatments that they could have done, I guess, or if I had presented like much more severely, they could have done some sort of mechanical intervention where they would go in and actually open up the area physically, but through like a surgical procedure. But at the time, that wasn't being considered, and it was more just like watchful waiting, and we're gonna do some additional studying when we can and get to the bottom of this. So
okay, so let's jump then back to the other side of the MRI. So you get those results. At this point, you know it's a stroke. When did the conversation come around this kind of interesting type of stroke that many of us as PharmDs probably have never even heard of or considered a thing? So maybe talk a little bit about what that stroke was, and then from your perspective, what it felt like to, first off, now understand that it's a stroke? Because you were very relieved, it sounded like, at first in the ER when you didn't think it was a stroke. So what was that like now, getting that result as the patient?
Oh, I was pretty pissed because like I'd taken care of myself most of my life, and I done my best to have like kind of have a prevention as the best treatment kind of mentality for, just because like as healthcare providers we know how quickly your health can deteriorate if things start to you develop hypertension, diabetes, or any sort of other kind of chronic disorder. It can really start to chip away at your quality of life and just like your overall satisfaction with life too, to be honest. So I was pretty mad and just kind of frustrated that this happened, and then I was starting to panic a little bit about, well, what does this mean? Am I going to have a stroke every couple of years? Do I have some sort of rare condition where I'm just prone to this? Or did something that I do that I'm not aware of trigger this? So there was just a couple of things where I was like, oh man, what the heck is going on? And the term cryptogenic didn't actually come up until the morning after my admission to the inpatient floor. It was the hematologist that came up, because by this time I'd been referred, like they'd consulted hematology, cardiology, neurology, and the neurologist saw me when I was in the ER, and the hospitalist, and they were both just like, man, no, this is very unusual, and we don't know why this happened. So we're gonna go ahead and do a lot more studies and get some blood work done just so we can figure out why this happened. Because at the end of the day, cryptogenic stroke, it's a term I remember like briefly from like one slide back in pharmacy school, because most of the time it's an ischemic stroke, or like in rare cases hemorrhagic, but most ischemic strokes are caused by predictable things, like either you're at a high risk based on hypertension, diabetes, just other comorbid conditions, drug use, maybe you're just like general sedentary lifestyle, things like that. So that term, again, like most of the time there's a clear cause, or like you're so old, or so old, you are older and you've just had more time to develop these or build up these kind of health risks or risk factors. So most of the time, yeah, cryptogenic doesn't really come into play, but when it does, that's when it kind of, I guess the key thing to remember is that cryptogenic stroke is just another term for ischemic stroke, but there's no clear etiology after you've ruled out the most common causes. So they look at you and they're just like, well, we don't know. Our initial evaluation, it doesn't have a clear reason why this happened, and that's when it starts warranting all the additional studies and evaluation.
So at this point, you mentioned neurology's on board, hematology's on board, cardiology's on board. Are you feeling like a celebrity at this point, Alex?
Yeah, no, I was pretty popular in the hospital. Like everyone wanted a piece of me.
Yeah, it
I was
sounds like
yeah, because my wife Kelsey was there with me pretty much the whole time, and she would say, like when she would go out for coffee or go grab like something from the cafeteria, that she'd come back and she'd hear like people talk like, oh, because I'm the youngest person on my floor by like 2 or 3 decades,
sure.
in the stroke wing or the step down unit, and like, oh yeah, well, it's got a 29-year-old the stroke, or like, I wonder if I can get on that, like students and other health, like just kind of gapping it up a little bit. So I was kind of a big deal in the hospital, but
it's kind of a big deal. It is a big deal.
it was nice to have them take it so seriously, and to also like just really, they were really motivated. All of them were to come through and figure out why it happened. And I was very lucky and happy with the care team I had.
That's great. That care team, what I wanted to get to was, what's their differential diagnosis list looking like? If it's not ischemic from a clear cause, it wasn't hemorrhagic, so no blood vessel burst. What else is there outside of the cryptogenic stroke that they eventually landed on?
So the initial things they were thinking were that it could be some sort of, like I had a structural abnormality in my heart, like a patent foraminal or PFO, which is basically like just a congenital defect where you have a small hole in your heart, and that actually causes a fair amount of strokes. My uncle actually had one due to a PFO when he was not too much older than me, but they were thinking about that. They were thinking about some sort of subclinical AFib, since that's also a very common cause for strokes, and that's why they were thinking that, and just like other things that could, like rare kind of things like, oh, you have some sort of rare immune condition or inflammatory problem, or you're hypercoagulable for some reason. So they were they were casting a wide net just because, like, well, what could potentially cause some sort of clot? We don't really know, so we're not gonna like narrow our vision too much. But the initial thoughts were, well, they were really quick to get me in for like a bubble study to rule out the PFO with an echo and TE and TEE. And then also that they were thinking, well, maybe it's some sort of inflammatory vascular disease or vasculitis. So they had a vascular surgeon come in and do a cerebral angiogram. So they took a wire and just ran it up through my arm and did some imaging studies there. And everything kept coming back like, oh, you're otherwise healthy, you're doing great. A lot of the blood work that they did for like the rare immune condition, like the rare inflammatory conditions that the hematologist ordered, we're not going to come back for a couple weeks. So, but all the initial stuff came back. It's like, yeah, we don't know what's going on, and like you're doing otherwise like everything's coming back healthy. And they kept mentioning cryptogenic, and like, well, we might not never know, but we're going to keep doing studies. We're going to keep looking. So that was kind of the general consensus, yeah, each and every day.
So you mentioned a number of different things that, kind of can contribute to or be the underlying cause of the cryptogenic stroke. I'm going to ask about two in particular because, at least to me, they're probably the most common in the list. So the PFO being essentially the hole that connects the two atria. You mentioned the bubble test. So can you describe a little bit about what that is and what they're looking for there? And then the other one being the AFib, a specific type of AFib. And so how are they looking for that? And which process did you go through to check for the AFib?
So the entire time I was there, I was hooked up to a telemetry unit. So they were monitoring my heart rhythm the entire time I was there, just to look for any kind of paroxysmal, or that's the fancy way of saying just random AFib that just kind of presents for no good cause or just kind of shows up. And even a short event, the cardiologist told me, like a short stint of AFib can throw a clot and cause an embolic stroke. So they were just kind of watching to catch if there was anything that came up in the hospital. And eventually they discharged me with a Holter monitor to wear outpatient for a couple of weeks just to see if we're going to keep looking. But again, they were starting to suspect that it was not going to be AFib based on my age, general, like relatively healthy history, and the fact that the stroke was localized. The cardiologist said that he had said that, well, most of the time when a clot goes from your heart to your brain, it'll break apart and affect multiple areas. But since mine was very localized, they were not as suspected. They didn't suspect it as much. But kind of talking more about the PFO studies, it was initially they just did a TTE, an echo, where they just kind of held up the ultrasound machine to my chest and kind of ran it over. And while they were doing that, they injected me with agitated saline, which was just like a bunch. They just shook up a syringe full of saline just to kind of get bubbles going. And they injected that into my vein, and it went straight through. And what they were looking for is to see if there was any traveling of those bubbles across the atrium where the PFO would be, to see if that was what was happening or what caused the stroke. Because normally it would follow the traditional path, but if there was a PFO or a hole or some sort of abnormality, it would if the bubbles would kind of show that pathway or that abnormality. But thankfully it came back negative, and they repeated it because the first study was a little bit low quality, and then to be extra sure, they did a TEE, a transesophageal echo, where they put the scope down the back of to my throat so they could get a much higher quality resolution image. And I was sedated for that, or under general anesthesia for that. So I don't remember that at all, but it was thankfully quick, and I painless. So
you said like to be extra sure. I think you said maybe at one point in a note your uncle had this going on. Was this the family history? Not direct family, but somewhat related. Why they kept diving deeper and deeper, or is it normal for a negative finding to then lead to a TEE afterwards?
Yeah, so I don't think they were as suspective of they weren't entirely sure. So they were just trying to dig deeper because any negative finding kind of warranted a follow-up just to really, really be sure. And I think I was starting to frustrate them a little bit because they couldn't find anything. So they were just trying to cover all their bases. I don't believe, and I'm not 100% sure, but I don't believe, and I think I recall the cardiologist saying that the PFO defect is not like an inherited thing, and it shouldn't be anything that they would expect to find. Or, well, they shouldn't say that. They weren't expecting that to be a higher likelihood for that, just based on my uncle's history. And my other family history is relatively, uneventful. Like my dad had prostate cancer, but that's since resolved. And other than that, like my grandfather had a DVT after surgery. But otherwise, like, we thankfully don't have any sort of like chronic health conditions just persisting throughout our family. So there wasn't, I guess, like they weren't really gunning for anything, but they were just trying to rule out all the, like, I guess, quote unquote, obvious or easy to detect things initially while I was inpatient. And given the fact that I was inpatient, they could do all the studies at their convenience since I was very available. So
The amount of times that I have seen a bubble study ordered or completed in the hospital I work at, and I never known how it's done or what they do. So thank you for sharing that. That's actually really simple and interesting. So that kind of wraps up, I think, cardiology's input on the situation. We still have hematology and neurosurge, though, who are hanging out. So hematology, they were looking at, to my understanding, like hypocoagulable states, malignancies, and there was something about vasculitis. Like where do all of those fit in?
yeah, so the main things that the the hematologist was looking for was just any sort of like just kind of rare blood condition or genetic defect that would put me at a higher risk for like a clotting event. So lupus was something they were looking for. They were checking to see if I just had, for whatever reason, just clotted really quickly, or had some sort of underlying disorder where it was just part of who I was. But the vasculitis was more, I guess, that was a consult to the neurosurgeon rather than neurology. At this point, again, I'm not trying to say anything about neurology, but the stroke already happened, and we're moving on to like secondary prevention and things like that, or finding it out. But neurology didn't have as much to, I guess, contribute at this time, since it was already kind of being deferred out to more imaging and actual procedure based things. So neurology came through every day just to kind of check in on me and see if I was improving, and I was getting better coordination. I was able to do a little bit of finger to thumb movements, but that was still pretty slow and frustrating. And so yeah, the vasculitis was ruled out by the vascular surgeon who did the angiogram, just to see if there was any sort of just weird thing I was just born with or developed over time. But it would have, again, I don't think they didn't know what they were going to find, but all the imaging came back, oh, you're otherwise healthy, your veins look great, and yeah, we don't know what's going on, but they were always great about just like making sure that I knew that they were going to keep looking, at least until they kind of completed all these stuff they could do inpatient. So that was a overall three days worth of in and out of just kind of procedures and just imaging studies and labs.
So Alex, I wanted to take a small step back. So you did mention the Lovenox in the ER. As I understand, you started a couple of other meds while you were inpatient still before discharge. You want to talk about what those were, and then did you start those in the ER and then continue throughout your entire stay? Did doses change? What did that look like? And were those the only meds you were on while you were in the hospital?
Yeah, so thankfully I wasn't hooked up to an IV or anything during my stay, and didn't require any sort of additional medications or things to feel better. So they gave, I think the first dose of aspirin they gave me was 325, and they gave me just 75 milligrams of clopidogrel and atorvastatin 40. And then I got daily Lovenox injections while I was in the hospital, just as, I'm sure part of their DVT prophylaxis, since I was mainly on bed rest and I was just exhausted to begin with. And then they continued the dual antiplatelet therapy. They told me, like, just as, because at the end of day 3, I was getting, like, I guess back it up. I was the oral medications I was getting were aspirin 81, clopidogrel, and atorvastatin. Those were my daily meds I got while I was inpatient. And when I was discharged, they told me they were going to keep me on the dual antiplatelet therapy for 1 month, and then they were going to let the neurologist and hematologist all kind of collaborate to figure out if I was going to continue the aspirin or the clopidogrel for secondary as single antiplatelet therapy, and that I would likely be on the atorvastatin for quite some time, long term, for both of those, and antiplatelet therapy.
So with both aspirin and clopidogrel being on your daily medication regimen in the hospital, and then you had alluded to only continuing one, maybe, after neurology and cardiology chit chat. Which one would you prefer? Like, and what's the difference between them?
Yeah, so for me, I was kind of at the mercy. Of course, after getting discharged, I was combing through all the stroke guidelines again, and the current ones from the AHA and ASA would basically say, oh, if a stroke happens, like, you're going to probably be on several medications, for either blood pressure control, if they find diabetes or AFib or something, those medications, but also, probably a statin long term, and also dual antiplatelet therapy for the range that the guideline said was like 21 to 90 days. But the neurologist was like, yeah, no, after 30, the bleed risk starts to get a little bit unacceptable. So we're going to just back you off to 1. And the decision between which one was, the initial talk was from the neurologist was aspirin 325. And again, I was very hyper fixated on all the doses for everything, because I was so, just anxious about not having another stroke. So I kept sending them messages, and probably being an annoying patient a little bit, like, well, why not 81? Why not like clopidogrel as single antiplatelet therapy? The guidelines didn't have an emphasis on one over the other. And the data comparing the two of them is very small. Like, I think there's only 1 or 2 studies, and they're older, and I don't fit the patient population for any of them. So how much it applies to me is where you start to get like a really gray area on, like, well, what do we do for this patient? And it ultimately, after kind of talking back and forth, we kind of settled on clopidogrel for single antiplatelet therapy, just because I was, again, I'm not just saying one's superior or the other for every patient, but for me, I was more comfortable with the fact that clopidogrel has a little bit less GI bleed risk, since it doesn't do any COX inhibition, and had a little bit better efficacy in terms of stroke prevention, based on like 1 or 2 clinical studies from a long time ago. So how much it applies to me, who's to say? But I was more comfortable with going forward with clopidogrel, and I was just a little nervous about, like, well, why are they doing a higher dose of aspirin? Like, don't we want to stay more COX-1 selective and not COX-2, where you get more of those net vasoconstriction with the anti-inflammatories? And so again, like, either one probably would have been fine, and I probably would have voted still probably steered towards aspirin 81, just for using the lowest effective dose. But again, not my specialty. But we ended up going with clopidogrel 75, and that's what I currently take every day, along with the atorvastatin 40.
With your PharmD background, but also understanding, that you're a relatively fit young individual. I'm looking at your lipid panel, your family history. What part of you is wondering, and you mentioned it a couple of times, like, these guidelines are older studies, but not only that, I'm not fitting the patient population. I'm looking at my panels, and I'm on a high dose statin. Like, what part of you is wondering, how accurate are these recommendations? And at any point, do you feel lost because of your situation? And, like, does the data apply to you? How are you handling those emotions?
Yeah, so I guess for the most part, I was fine trusting the guidelines, even though, again, I don't really fit the general demographic, just because, an ischemic stroke happened. Regardless of why it happened, I want to do everything I can to prevent it. And we know that even though I don't have high lipid levels, statins do have anti-inflammatory properties, like plaque stabilizing benefits. So I was like, all right, well, regardless, that's nice. And, for the antiplatelet therapy, it was kind of a thing where, again, I was still wearing the Holter monitor, and I was like, well, definitely keep taking this because I don't want to have a just random ping of AFib and just throw another clot. So now that all that results come back and everything's been clean and no identifiable cause, I'm still fine with continuing it, and I'm okay with that because it's like, if I have to wear a seatbelt to or safety net, I have to use the safety net, that's fine. I'm not gonna throw a fit about that, and I'm just very thankful that I got out of it relatively unscathed, long term damage wise or disability wise. So very, very grateful for that. And we do have since everything's kind of like I've been referred off, or they've closed off all the consults, and I graduated speech and occupational therapy. Big deal, yeah. I have a specialist follow up at a teaching hospital with a vascular neurologist who hopefully can provide a fresh set of eyes and maybe do a little bit more investigation into more potential or other rare causes, or the things that are so obscure that you'd only see them on like a episode of House, or like just drama medical TV and stuff like that. So that'll be in January, and again, they still might not find anything, and if I have to keep on this for the rest of my life, then that's just the hand I got, and I'm not going to complain.
You had just mentioned like, well, that's the hand that I was dealt, if you have to take Plavix and atorvastatin for the rest of your life. I just want to say I totally respect that out of you, because a lot of people will take a bad situation and say, woe is me, I'm the victim, life is out to get me, like this is the worst, and then just ride that for the rest of their life. But it sounds like you've experienced this, you've understood like, what happened, not necessarily why it happened, but that's just what happens in life, and you're going to move on from it. You're not going to let it control you. So I commend you on that. That's incredible. So then once you got that MRI the next morning after your presentation to the emergency department, the neurologist had to read that MRI, interpret that MRI, and leave a note in the chart. What specifically, what like terminology did they use for the stroke that the MRI showed?
The concise description of it is that it was a right middle cerebral artery stroke, or a right MCA stroke, which is one of the main arteries that supplies the different regions of the brain. And mine happened to be occurred in that one specific spot, and you can kind of see that on the MRI as well. So that's and also that's kind of why they started to looking at other potential causes, and why they were thinking, well, it's isolated to the MCA and relatively localized. So that kind of played into the additional workup, and kind of what their suspicions were for certain etiologies.
So Alex, at this point, you're approaching discharge. We know what meds you're on, what you're going to be taking orally, potentially for quite some time. Once you get out of the hospital, what does that outpatient care look like, and what do you think was some of the most important steps you took right after to get you back to where you are today, where you can make a complex YouTube video describing this experience?
Yeah, so it was a lot of doctor's visits, of course, a lot of follow-up. It was establishing a PCP, because I didn't have one since moving down from St. Louis to Dallas. So getting one, my wife and I have the same one now, which is convenient. And then just the most important thing, I guess, for at least the recovery part, since we'd established the secondary prevention medications, those are kind of set for at least the initial period. There's just a lot of relatively decent amount of outpatient rehab therapy. And in my case, they had referred me for physical therapy, occupational therapy, and speech therapy. And speech therapy is pretty clear what that was, because, I had garbled speech, and, chewing and swallowing was still a little bit hard because I only had really the coordination on the right side of my face. So I was on a soft food diet for a while, just because that's what I could handle. And thankfully I didn't have any trouble with like choking or aspirating, because that was another concern they had, was, make sure he can swallow food so he doesn't like just end up with some sort of secondary infection. And the difference that I didn't really appreciate between occupational and physical therapy is that the layman's term that was explained to me was that occupational is kind of from the waist up, focusing more on your extremities and that sort of movement and or your hands, and then the physical therapy is kind of your core and your lower body. And for me, thankfully, my deficits were localized to just my left hand, and I guess compensating up to my left arm and the left side of my face. So I only ended up pursuing occupational and speech therapy. I did that twice a week for about a month and a half, and it was just a lot of and again, even though that was in place, the main work that was most impactful was the work I did at home when I was resting and recovering, just making sure I built in time and had the discipline and just remember to keep doing the exercises several times a day. There was a lot of saying nursery rhymes to get my like the limericks and all that stuff, and I was just goofing that up for a while and getting better with it over time. But it was just a little bit of a frustrating struggle during that initial part, just because you think you're not expecting to have to take a step back like that. At least I wasn't at this point in my life, or even put my life on hold for something like this. And so it was it was very frustrating, but to have to do all that and just kind of annoying distraction. But it was probably the most important thing for my recovery, and I just want to highlight that is part of like one of the critical aspects of care after a stroke is going to be just the rehab portion, because the meds and stuff aren't going to get you back to your baseline. They're just going to help prevent a secondary event in most cases. So just want to make sure that's shout out to all the rehab people that do the good work like that. So
my cousin's an OT and my sister's planning to go to PT school, so I can impress them with this new knowledge of below the waist. How has your home life changed at all? And how much has your wife had to adjust her schedule for any of your rehab or post-stroke complications?
Yeah, so we're both very lucky that we work from home for the most part. She is does voice acting, so she does auditions and stuff from home, and then if she needs to go into studio, she can just make a short trip up for that. But very lucky that I had her around for as long as I did, and we did have family come in as well to kind of like help out with the dogs and just coordinate meals and things like that. But home life, I mean, I was using a cane out of excess of caution for just a few weeks when I would have to go out or had to be out and about for doctor's visits and physical therapy, or just any rehab therapy. But you just having to pause for driving and I guess walking the dogs on my own. Like I wasn't really, just because I only had really one functional hand, and our dogs are really, really strong, and they can outrun me and pull me over if I'm not careful. So just I guess I had training gloves or training wheels on for a while, and I didn't appreciate that for at the time, but it was I'm very, very happy I had the support of my wife and family for that acute period following my discharge.
Alex, how many days out are you today from the event of the stroke?
Yeah, so it was August 26th.
Okay.
So that would be, we're about 3 months ish. Yeah, just over 3 months out.
And Alex, following this crazy experience that, us being in our late 20s now, I can't imagine going through it. Certainly would never anticipate something like this happening to me or my friends. So like, I apologize that it happened to you, but it seems like you're handling it, as Kristen said earlier, just as well as anybody possibly could. So again, kudos there. But what are some maybe take-home messages you have for the RX Teach audience? Bearing in mind that we have a lot of healthcare providers watching and subscribing, but also a lot of patients. So curious, what do you want the people to really take from this?
Yeah, so definitely being familiar with the signs and symptoms of a stroke as it's happening. They're not always going to be like as obvious as mine were, where it was all three of them, like face, speech, and arm, like face droop, one-sided, slurred speech and kind of a bum arm. They can present in a lot of different ways. Some people, it could be, they suddenly very confused or disoriented. They might just kind of lose cognition and they're just their normal cognitive faculties, or they might not be able to get up if it is a more severe or walk around. So it can present in many different ways, but if you do suspect something, regardless, I would just, like, if you think, well, that's not going to be bad, in my case it was, but just act quickly and seek emergent care, because you do have that short window with TPA where it could really improve their outcomes. But also, just in case things are super severe, like you don't have, no one can do resuscitation or emergent critical care from their home or wherever it happens. So act promptly. And then I guess I would just also, this is kind of like not a cautionary tale, but like a reminder, just even if you think that something happens, it's not no fault of your own, for whatever happens, just do your best to, as a habit, just to invest time, energy, and resources into your own health as a preventative measures, just to avoid, having to end up in the hospital for one thing or the other, and just as best you can, make sure you establish a primary care, and you make sure to talk to them about ways that you can manage your risk factors for a variety of chronic conditions that can come up. So just do your best to stay ahead of any problems you might have that could occur medically over your life. And when they do happen, just make sure you address them promptly or appropriately, and not just kind of blow them off too. So that's harder to do for some people than others. We all know those kind of stubborn people in our lives, but just being a support for them when they need it as well.
I think it's incredibly important. One of your last pieces of advice, just taking an interest in your own health and researching what you can. And I understand Dr. Google might not have all the correct answers for our patients out there who have access to Google, and not some of the more complicated, up-to-date resources that us healthcare providers do. But from my perspective, when I counsel patients, if they even show a fraction of interest in what I'm saying, the whole conversation and the whole session goes so much more smoothly. So to all the patients out there, it means a lot to the healthcare professional if you are genuinely interested and curious and want to learn. And I don't know if we want to edit this in later, but I wanted to ask Alex, you mentioned a Holter monitor that you were wearing frequently. I don't know if that was in the hospital or just upon discharge, but could you explain what a Holter monitor is, why you had to wear it, and when you got the results?
Yeah, so a Holter monitor is a mobile cardiac rhythm machine that just basically, mine was kind of like the Iron Man crest. It just kind of sat over my heart, and it would record and send off the rhythm readings to a telemetry unit somewhere else in the States. So they were having me wear that as just a way to kind of catch any potential outpatient arrhythmia that they didn't detect while I was in the hospital. Because if it did turn out to be, oh, you do have AFib, well, we got to switch you over to an anticoagulant and start pursuing you got to do some sort of rhythm control, rate control, ablation, some sort of procedure. It just kind of opens up a whole new treatment plan and strategy. So that was what they were trying to do. They were trying to rule in, rule out, but just out of excess of caution to see if that was potentially the precipitating cause. I wore that for about 2 weeks, and I got the results back about 2 weeks later. I had to mail it back off. And if there was initially talks about doing an implantable loop recorder, which was something that would basically do the same thing, but they would inject it subcutaneously under my skin, and I would wear that for 2 to 3 years, and it would just kind of on a daily basis send the readings off to another telemetry unit. But after meeting with the cardiologist and getting those results back from the initial reading, like nothing out of the ordinary, healthy heart, healthy rhythm, and just reaffirming that, like, well, based on your findings and the fact that you're so young, he was so like, oh, you don't have any risk factors for having AFib, because some people my age do have AFib, but they have kind of a laundry list of other things going on with them, and also the fact that the stroke was localized. And he said that typically for cardioembolic strokes, or strokes that come from the heart, typically sees it kind of being more diffused in multiple areas affected on it, which would show on the MRI. So given my finding, again, can't say for with any degree of certainty, but more of a possible that it was just a thrombotic event that just happened locally for some reason spontaneously, and just kind of resolved on its own quickly, thankfully. But yeah.
And I'll put a study here just looking at the incidence of cryptogenic stroke being caused by paroxysmal AFib. It turns out that even if you find paroxysmal AFib in a cryptogenic stroke, it's only the causal agent in about 42% of the time. So it doesn't necessarily even answer the question, although for folks less than 65 years of age, it's actually more frequently the cause than folks older than 65, and we'll put that link down below as well. Guys, I don't have anything else to add. I think this was really great. I mean, it's rare we get the patient perspective and that person is so well versed and has the clinical background and all of this. Like, I think this was a fantastic thing.
Yeah, no, this was really great, and it's always nice to get to talk to other people who are interested in who kind of share the same space, whether on social media or just having a platform to talk about pharmacy and medical education and just health in general. So
I don't know about you, Brenton, but I know we worked with you, Alex, before. So not only was I invested in all of this because I feel like I have a personal relationship with you, but you're just so atypical, healthy, young. It really put into perspective, like, this could happen to me an hour after we end this call. Like, and who's to say that it won't? So it's just educating myself from your experience. So I also think that's the reason it'll be very beneficial for our audience.
Mm-hmm.
Yeah, it's very, very eye-catching top line items, like a cryptogenic stroke.
Yeah,
it sounds cool. Definitely sounds cool.
It's a good name, that's for sure.
It kind of made me think of this something the cardiologist said when we were at follow-up. He was like, most of the time when you think of stroke, well, they teach you in medical school, he says, like, when you hear hooves, think horses, not zebras. But I was
a zebra, buddy.
I was cryptogenic zebra.
Yeah.
We should, Brenton, we should call up Dr. Lynch and say, hey, guess what?
Yeah, we found one. Yeah.
Gotcha. Yeah. No.
Glad that other schools of pharmacy use that analogy as well.
Yeah.
Yeah. No, and again, that's a very, I think, appropriate way to think of things initially, especially in like kind of an emergency setting. It's like, well, let's spend 3 days worth of time doing imaging studies on a niche case of potential causing stroke, and like, well, no, let's do something else that we know is probably going to be more appropriate. So yeah, I didn't fit the picture, so rats.